The Psychedelic Report.
Psychedelic drugs
have played their part in America's long, strange trip toward an understanding of mind-altering drugs.
The psychedelic news.
Leading physicians, scientists, and experts share their wisdom about psychedelic medicines and healing.
50 years ago, psychedelic drugs were at the center of America's counterculture.
The brightest minds in psychedelic medicine. The Psychedelic Report.
We use the ketamine-assisted psychotherapy model that happens to have psychedelic effects that were not predicted when the drug was first developed.
From researchers to investors.
I think the biggest mistake we've made as a culture is the war on drugs.
To physicians to shamans and nonprofit pioneers.
Psychedelic drugs.
Recent research suggests some of them could have legitimate uses.
The psychedelic news
brings you diverse perspectives from the front lines of this exciting movement. The Psychedelic Report.
The Psychedelic Report was brought to you by Apollo Neuroscience and produced by Future Medicine Media. Welcome to the Psychedelic Report, your single source of truth for the psychedelic news. I'm your host, Dr. Dave Rabin. I'm a neuroscientist and psychiatrist trained in ketamine-assisted psychotherapy as well as MDMA-assisted therapy. Today, we're discussing an article recently published by CNN on August 5th, 2024, entitled, "With FDA Decision Looming, Bipartisan Group of Lawmakers Urge Support for MDMA to Treat PTSD." This is a fascinating article and very detailed report discussing how the impact of MDMA-assisted therapy for PTSD is so significant that politicians on both sides are coming forward to urge President Biden to make sure that this treatment gets over the line. The vote by the FDA on MDMA-assisted therapy clearance or approval is expected on August 11th of 2024, just a few more days away. And with that decision looming, a decision that is critically important for all veterans and any American with PTSD or with suspected PTSD, which, as we discuss, could be as many as 15% of Americans, I have a very special guest expert to join me to discuss the state of affairs of PTSD treatment, the meaning of the approval of something like MDMA-assisted therapy for veterans, and what it could mean if the FDA decides not to do their diligence and trust the advisory committee that provided biased information to them about the risks of MDMA therapy, which, from the study data, when practiced according to protocol, are minimal and less than most current antidepressants available. Our special guest today is Dr. John J. Miller. Dr. Miller is the medical director at Brain Health in Exeter, New Hampshire, and has served as the editor-in-chief for Psychiatric Times since February 2019. He has worked for 38 years as a clinical psychopharmacologist, most recently 17 years as a staff psychiatrist at Seacoast Mental Health Center in Exeter, New Hampshire. Dr. Miller completed his bachelor's in science in biochemistry at UMass Amherst, and he completed medical school and residency in adult psychiatry at UMass Worcester. Dr. Miller is also a diplomat of the American Board of Psychiatry and Neurology. Since 1998, Dr. Miller has presented more than 3,000 lectures throughout the U.S. on a wide range of psychiatric topics, including PTSD, post-traumatic stress disorder. You can find Dr. Miller in his monthly editorials for Psychiatric Times that he has been authoring since March of 2019. Dr. John Miller, thank you so much for taking the time out of your busy schedule to join me today.
Thank you, Dr. Rabin. It's a pleasure to be here, and I really enjoyed our last conversation and look forward to having a discussion with you about such an important topic.
I really appreciate that, and have enjoyed my conversations with you as well, especially given your expertise in the field of PTSD and your background on this, which is relevant today because we're just a few days away from the FDA decision around MDMA-assisted therapy as the newest, most successful and promising treatment for PTSD and chronic PTSD as well. And we have not had a lot of good treatments for these over the years. So I was wondering, could you run through for us the brief history of PTSD and kind of how we got here today?
Yes, I'd be delighted to. It's really one of those psychiatric or medical tragedies, which it's a diagnosis that continues to fight for treatment and acknowledgement. But we can go all the way back to good old Sigmund Freud in the late 1800s. He published a case series of women diagnosed with hysteria, and he proposed that childhood abuse was the likely etiology. In fact, the paper was called The Etiology of Hysteria. And it was very quickly scorned and shunned, and he was humiliated by his colleagues to the point that he retracted it. And at that time, it puts into context how suppressed or repressed or disconnected we were from the effects of trauma. My own grandfather was a medic in Germany in 1918, World War I, on the front lines. And, he was gassed. He saw a lot of really bad stuff. And when he came back, his life was changed, which my grandmother's diary reflects. And back then they called it shell shock, and it was viewed as a weakness. And if we jump ahead to World War II, one of the quintessential themes there was General George Patton, who basically slapped a bunch of soldiers who had been in incredible warfare and traumatic experiences and blood and death. And he called them sissies because they were basically suffering from PTSD. And Eisenhower ultimately reassigned him, which was interestingly, when he was reassigned to Northern Europe, the Germans thought that's where the D-Day was going to occur. So it has this interesting historical connection. But the good news was people with PTSD have continued to advocate for themselves. And the Vietnam veterans did an outstanding job saying, there's a lot here. You got to help us. This is not right. We're trying to help each other. We need your help. And finally, in 1980, not that long ago, Diagnostic and Statistics Manual of Mental Illness, the third issue, finally recognized and introduced the diagnosis of post-traumatic stress disorder. And basically, the definition has remained similar to today, so I won't repeat it. But what did happen in the early...
You said this was like 1980s when DSM-3 came out? 1980.
Yeah, DSM-3 entered in 1980, and that was when the American Psychiatric Association finally recognized post-traumatic stress disorder as a real disorder. So wow. 44 years ago, not a long time ago. I had just graduated from college, so it's in our lifetimes. And back then we had nothing to treat it. And we talked about it, and, there was lots of approaches. We didn't get our first drug approved for PTSD until 1999. And that was Zoloft, generic sertraline, which is the serotonin reuptake inhibitor. And it had showed benefit with a lot of anxiety disorders, as well as major depression and other things. And to Pfizer's credit, they studied it aggressively. They got approval. And a few years later, paroxetine got approval. And so here we are 24 years later. And those are the only two drugs that are FDA approved for PTSD. And they're not really that great. I mean, they work a little bit. They help some people. They work better in people who've had a single traumatic experience. They don't work well for people who've had a lot of childhood trauma or a lot of military trauma or a lot of just adult, tough life, living in dangerous places trauma. And that's the population that suffers the most. And ultimately, down the road, a lot of them end up with significant functional impairment and get marginalized, homelessness and unemployment and divorces and, financial issues and difficulty functioning. And so it remains this huge unmet need. In probably around 2009, 2010, one of our thought leaders in PTSD.
Before you go on to Bessel, when you talk about the unmet need, could you just give us an idea? Because you mentioned very importantly that PTSD wasn't even a diagnosis in psychiatry until 1980. And subsequent to that, it has been heavily stigmatized, even so, because it's a new diagnosis and it's widely underreported. Right.
Yes.
And trauma itself is often stigmatized. So we have some idea of the number of veterans and civilians who are reported to have PTSD diagnoses, but how many people would you guess or estimate, nationwide to suffer from symptoms of PTSD, treated or untreated? Because my guess as a psychiatrist who sees these kinds of folks is somewhere in the order of 40 to 80 million, but I don't know. I mean, it's just guessing.
Yeah. So I'll go to statistics, percentages, which gives me a frame around what subset of the population. And, based on papers that I've read, if you look at an experience that would rise to the level of meeting criteria for PTSD, which means you've had this traumatic experience, it either affected you directly or someone close to you directly, and those symptoms have persisted for 30 days or longer, because by definition, 30 days or longer. When you look at the percentage of people who've had a traumatic experience like that, it's estimated to be 50% of everybody in the United States, 1 in 2.
Wow.
If you look at the percentage that then go on to develop post-traumatic stress disorder, it's somewhere between 10 and 15%. So that's 1 in 10 people. Now, some of that may be mild PTSD, but a significant subset is more impairing. And one of the difficulties with DSM in psychiatric nosology is that a lot of severe personality disorders, especially what we call a borderline personality disorder,
trauma related.
up to 90% of them had severe childhood abuse, most of the time sexual abuse, severe emotional abuse, physical abuse. And so while their brains are wiring between the age of 2 and 15, they're always in a state of being fearful, afraid, unsafe, unprotected. And not surprisingly, that wired brain then gets carried throughout life, and we give them a label that unfortunately gets stigmatized negatively. We're working on that. But the bottom line is PTSD percolates throughout many DSM diagnoses. You see it comorbid with major depression. You see it comorbid with bipolar disorder. If you have PTSD, you're more likely to have your first psychotic episode of schizophrenia. So
addiction, substance
exactly.
use.
Yeah. And that's another whole podcast for you, right? Is addiction as an attempt to self-medicate PTSD. And then people focus on the addiction, and the actual reason for that dysphoria or distress is put into the background.
You're listening to The Psychedelic Report.
That leads us up to Bessel van der Kolk.
Yes. So he started at the Boston VA in 1978 and immediately started working with these really traumatized vets that he developed a passion to try to help, and continues to do that to today. His iconic book, The Body Keeps the Score, is a classic. And I recommend it to a lot of my patients to read, as well as my colleagues. But he and a group of his colleagues who strongly believed in the importance to define complex PTSD, which was a subset of PTSD that included increased functional impairment, significant negative kind of self-judgment, more severe interpersonal conflicts, and behaviors that could be aggressive from a self-protective sense, that those kinds of symptoms, complex PTSD, should be differentiated in the DSM, Diagnosis and Statistics Manual, as a separate diagnosis. And they lobbied hard, but ultimately in 2013, and again in 2021, when the DSM-5 came out in 2013 and DSM-5 TR in 2021, they ignored the diagnosis of complex PTSD. And I professionally and personally, I think it was an egregious error, and it basically continued to distance the subset that need help the most from bringing attention and clinical attention and screening attention to give them more visibility and to help them.
Yeah, that makes a lot of sense. And so enter MDMA-assisted therapy.
Yes. So as long as I've been practicing for psychiatry for 38 years, and throughout that time, we've never had great treatments pharmacologically. Some of the best treatments for PTSD of all types have been eye movement desensitization and reprocessing, what we call EMDR, and dialectic behavior therapy with Marsha Linehan, who had her own traumatic experiences, went and got her PhD to learn how to help herself, and ended up developing DBT as a tool to work with other people who've been traumatized to work on a lot of these behavioral and emotional and self-regulatory symptoms. And to date, DBT has the best evidence base for helping people with what we call borderline personality disorder, but underneath that really is the symptoms of post-traumatic stress disorder, complex post-traumatic stress disorder.
Right.
So we have EMDR, we have DBT, we have cognitive behavioral therapy, exposure therapy. And in the right hands with the right therapist, they can be very helpful. But what's missing is tools, in our case, as psychiatrists, medications that may help facilitate the therapists in either treating symptoms to allow a more aggressive therapeutic approach, or in the case of MDMA, which I personally think is a really smart strategy, early in the treatment to give them an enactogen, MDMA, which is sometimes called an enactogen, releases a lot of serotonin. It improves the ability of social comfort. It makes people more able to access what otherwise are difficult, painful, traumatic memories. And when that's done, in the case of the clinical trials for MDMA, after 3 intensive therapy sessions with 2 therapists to get to know each other, so now you have trust and relationship, and then you just have 3 sessions where you take MDMA, which helps facilitate the unmasking or the bringing to the surface material that had been stuck. And then that becomes the foundation of the next 9 sessions, which are intensive, all with the same therapist, safe environment, etc., to then process and reconsolidate those memories. And this is a simplistic example, but from what we call the amygdala, stored visceral, raw reptilian emotion, where it just pokes through and it's overwhelming, to reframe it from being stuck there to storing it in the prefrontal cortex where it becomes part of our biographical memory. And then it makes sense. And we can remember it without the amygdala flipping on our fight or flight in all of the other really difficult symptoms of PTSD. So the model I started following probably 15 years ago, and through my own research, after I read the vote by the advisory board, I was really perplexed. So I did
the June 4th vote.
Yeah, the June 4th vote by the advisory board, and the advisory board voted 9-2 that it did not show good enough efficacy versus harm, and 10-1 that it did not have better benefits than risks. And I was really disturbed, surprised, and frustrated by that. And I don't know the answer to this, but the question I asked myself was, what background did those advisory board members have on PTSD, on the big picture, on the fact that MDMA was registered as a new drug application in 2001. That was 23 years ago. So the FDA started working with MAPS and the people looking at MDMA for PTSD 23 years ago. And in 2017, which is 7 years ago, the FDA awarded fast track status. And in all the documentation from 2017, there was this ongoing collaboration where, from my reading, a lot of the issues that were raised by the advisory board had already been talked about and processed through that correspondence between the FDA and MAPS over those 7 years that the clinical trials were being done. And so it left me confused. And I think the way I made sense of it, or still make sense of it, not that I agree with it, is that it seems like the missing link with the FDA is having a lack of awareness and understanding of the fact that this treatment is really a psychotherapy treatment. And, there are 15 sessions, very long sessions with skilled clinicians who are trained to work on helping someone rise above the difficulty and the pain and suffering of PTSD. And the purpose of the MDA is very specific. It's at the early part of treatment to kind of shake the traumatic experiences loose so that they'll be more easily accessed, and then allow for those final 9 sessions to help the person who's suffering to help them reintegrate. And as the study showed, there was a significant improvement in the CAPS-5 score, in the Shan Disability score. And so the bottom line is...
And the CAPS-5 is a no joke, serious survey assessment of PTSD. It can't be just done online. You have to have somebody administer it. And it's a very extensive questionnaire.
And well-validated.
And well-validated, right.
Validated. And the other part of the studies that I was really impressed at, it was multi-ethnic. So you crossed a whole line of cultural and racial and gender demographics. And in addition to that, the majority of people met criteria for severe PTSD. I think it was like 65 or 70% had severe and the other 30% had moderate. So you're not talking about people with mild PTSD. You're talking about really impaired individuals. And these are the people that untreated are going to end up disenfranchised, homeless, incarcerated, divorced, suicidal, or tragically commit suicide, and a turn to substances as a way to try to self-medicate something they feel they can't control, but they know they need help for.
Right.
And so you put it all together, it was a disappointing finding that from my window, it seems like they didn't utilize all the data that should go into such an important decision. My biggest concern is that if the FDA does not vote to approve it, regardless, and they've done this before, they did this with one of the monoclonal antibodies for Alzheimer's. It was unanimously denied approval, but the FDA, based on other factors in their bucket of information, ended up approving it. So ultimately, the FDA is just taking the advisory board's decision as an opinion or a recommendation. But my hope is the FDA looks at the big picture and all of the information they have and all of the input from credible sources. Because if they do vote to deny approval, my fear is it's going to delay important, necessary, essential, compassionate treatment to people with severe PTSD, possibly for decades. Yeah. And it's not fair. It's just not fair to the people who are suffering. It's not fair to the clinicians who know what needs to be done and who just need the tools to do it.
You're listening to The Psychedelic Report.
Yeah, it's in the complete disservice of patients and veterans, which are disproportionate per capita rates of PTSD and suicide rates. So this, the effect on the vulnerable patient population that just finally now received their diagnostic code, right, just 44 years ago, to be able to have an understanding of what's going on that will be paid for and covered as treatment of an illness, only had two medications, right? Just to sum up what we've been talking about, two medications that work, that maybe induce remission in like 30% of people.
Yeah, they don't work that great.
And they have lots of side effects, right? Like Paxil has known severe withdrawal effects that make it very, very hard to stop taking. Both Zoloft and Paxil have black box warnings, which is the most severe label an FDA can give to any drug for increased rates of suicide, right, in young people, in children and teens who are taking people under 24.
For that box warning, I'll give it context. Any drug that's an antidepressant gets that warning.
Right.
And it was based on the FDA reviewing 10,000 patients. At the time, it was in the 90s. So it was SSRIs, SNRIs. And there fortunately were no suicides, but there was a highest signal for people under the age of 25 for suicidal thoughts and behaviors. So we in psychiatry have never really believed that to be a good decision by the FDA's perspective. But to your other point, SSRIs have lots of side effects. And not to mention, Paxil has one of the most severe withdrawals, but all of them do.
Right.
Because you basically, in the longer you're on it, the higher dose, the worse it is. Right. But you also have cognitive dulling. You have emotional blunting. You have people who become a little apathetic, which other people around them know. And they think they're not depressed. It's like, no, it's not that you're not depressed. Your brain's a little blunted.
Right.
Because, when you raise serotonin, you're in your brain circuitry, you're lowering dopamine, which is the cognitive, motivational interest neurotransmitter. And not to mention about 70% or more have significant sexual dysfunction.
Yeah, exactly. And those are very, very significant side effects that MDMA assisted therapy delivered under protocol does not have. right? And MDMA, again, bringing it full circle, what you were talking about earlier, this would be only the third medication, FDA cleared medication, that is really being cleared as a therapy accelerant, right?
Yeah.
Like, it's not the MDMA alone that is having the effect. It's the MDMA that is neurochemically amplifying the safety cascades in our insular cortex and limbic system that tells the amygdala, hey, you don't need to be blowing up right now. We're not under threat. We can divert resources back to the empathy, recovery, healing systems, right? And it's basically helping people feel safe enough to remake meaning around past traumatic events.
Yeah, I love your use of the word accelerant, because, one of the biggest challenges in psychiatry is the delayed effect of any kind of treatment, be it pharmacotherapy or medication therapy. And to have a drug like MDMA, which at the end of the 6th session, you're done with the MDMA, and now you're going to dig into the real work. And the MDMA has been there to amplify, to accelerate, to allow that traumatized brain to access the roadblocks so that hopefully over the next several months, they make gains. And as the trials have shown, a lot of gains have been made with this protocol.
Right. And so it makes sense why so many clinicians and researchers are upset and surprised and screaming about making sure the FDA makes the right decision and evaluates the whole data set on this study and understands and actually looks at the outcomes and actually looks at the risks and evaluates them objectively, because it seems like the committee, the advisory committee that voted on June 4th, was not objective and didn't have the expertise in PTSD or psychedelics or the context of PTSD and what we have to date that's not working and who's suffering, to basically make a statement with their vote that says, we believe it's safer to continue to live with PTSD than it is to receive MDMA-assisted therapy from a trained professional.
I would say ask any family member of someone with severe PTSD if they believe that statement. And
I don't know a single person who believes that statement.
Yeah.
But if you're a clinician or a person with PTSD or a family member, you definitely know that's not true.
You live it, you see it. It would be like saying, let's not give people with schizophrenia antipsychotic medications. And it's like, why would you not do that? Look at what they do. They decrease hospitalization, they decrease suicide, they increase functionality. The earlier you treat, the better their outcome. So let's get them on board and let's use them. And I really do. I think it's a fair analogy for MDMA in the context of PTSD.
Except MDMA has even way less side effects than antipsychotic medication.
And you're only using it for 3 sessions. The analogy was meant to be in terms of providing a good treatment that's needed.
Exactly. Even with that significant side effect profile antipsychotics have, we still don't deprive patients and physicians of using them. And so what this really brings to mind for me, is the FDA vote on August 11th, which we just realized is a Sunday, but maybe it's August 12th, but sometime coming up real soon in the next few days is critical. CNN just published an article that's been around a few different places in the news right now that is entitled, "With FDA decision looming, bipartisan group of lawmakers urge support for MDMA to treat PTSD." And it's a really nicely written piece about bipartisan support for this treatment and moving this forward. And I think it's interesting to see this in the public media and the political environment in such a big way, but it does impact so many people. And yes, in my knowledge base, to me, this seems relatively unprecedented, right? And correct me if I'm wrong here, I'd love to hear your thoughts, because you've been at this a lot longer than I have. But when we think about, what's happened over this journey with MDMA assisted therapy, there was a radical anti-capitalist group that doesn't believe that veterans have a right to heal. But regardless, they are a group that is directly advocating and lobbying the FDA committee and the FDA to reject MDMA assisted therapy to treat all these people who are suffering in need that we just talked about. And I've never heard of that happening before, where there's a group actually trying to shut down a treatment from getting out. I've heard about protesting to make it out, but not the opposite. And then we also have clinicians now coming out and researchers saying, hey, you got to pay attention to this. This is really important. Like, we have to get this over the line. It's significant. And if we don't, it's going to be really, really bad, right? Like what you were saying earlier. And then we also have now politicians on both sides urging the president to ensure that this goes through. This is unprecedented, right?
It is unprecedented. And I think an important piece of all this is it's a paradigm changing treatment. In medicine and institutions have a hard time with paradigm changes. I studied as a biochemist before I went to medical school. And one of my favorite quotes about science and scientists and developing our knowledge base is that old scientists don't adopt new paradigms, they simply die off. Hopefully that doesn't happen. Hopefully that people will objectively look at all the new information. And even though, they've been doing the same thing for 30, 40, 50, 60, 70 years, the wisdom in them, or the collective goal of moving forward and with science and with medicine and with healing and with helping people, that we embrace the new paradigm changer, because in fact, it's going to make a huge difference in quality of life and functionality, and everyone wins.
I completely agree with you. And I think your background and insight has just been really informative and educational. I've learned a lot from our conversation, and I really appreciate you taking the time to join me today. I just wanted to end with, the FDA decision, again, is just a few days away, and listeners are going to be wondering, do we just sit on our hands the whole time we're waiting for this announcement, or is there anything we can do? And I wanted to finish by just asking you, is there anything people can do who are listening to try to help?
Well, I think we're seeing some of that with, the Congress and the Senate, where my guess is the reason that they're, lobbying President Biden to get involved and to support the approval of this treatment is because the senators and the Congress people are getting a lot of calls from their constituents saying, we really need this treatment. My son, my daughter, my husband, my wife needs this treatment. So certainly the louder the noise from the general population, that does have an impact. And the article you referenced today is an example of that. But we as clinicians, and I certainly, applaud you and your efforts in your podcast and all that you do to try to move our treatment paradigms forward, are important. But it's one of those cases where we have to verbalize, and we need to ourselves as treaters and clinicians and our patients, go through our channels to advocate and make it clear why this is important. And I know in my own case, I read an editorial every month, and hopefully that gets read, and hopefully that inspires people to talk more about it, like your podcast. So it's kind of a nervous week coming up because I've been excited about this model for years and was really expecting it to just move through based on the quality of the data, simply based as a scientist, based on the quality of the data. And when I ever heard the outcome of the advisory board vote, I was very confused and disturbed, which is why I did a deeper dive into it. And I actually went back and read the PowerPoint that was given to all of the people on the ad board. And so here we are, as you said, let's make it happen.
I love that. That's a great place to end. And I just want to thank you again, Dr. John Miller.
Thank you for having me, and keep up your good work.
Thank you. You too.
Thanks.
Thanks for listening to The Psychedelic Report. Visit us at thepsychedelicreport.com. This show is recorded weekly on Clubhouse with a live audience. The Psychedelic Report was brought to you by Apollo Neuroscience and produced by Future Medicine Media. While I am a doctor, I'm not your doctor. So please don't take anything you hear on the Psychedelic Report as personal medical advice, because we don't know you. If you have questions about anything you hear on this show, please consult with your doctor.